I'm Maximilien Barret, and I'm a gastroenterologist in the Gastroenterology and Digestive Oncology Department at the Cochin University Hospital in Paris, France. I'd like to briefly introduce our paper entitled Impact of COVID-19 Pandemic on the Gastrointestinal Endoscopic Activity in France, published in Endoscopy online on June 17th. This work was promoted by the SVED, the French Society for Digestive Endoscopy, and my co-authors are the members of the administrative board of the SVED, belonging to several French public and private hospitals. As many other European countries, France was hit by the COVID-19 pandemic in February, with about 100 cases diagnosed by March the 1st. The lockdown was decided by the government on March 17th, with more than 7,000 diagnosed cases over the territory, so our first aim was to measure the risk of contamination of the gastrointestinal endoscopist at the peak of the epidemic. It's also important to know that in France, over 90% of the colonoscopies are performed under general anesthesia by an anesthesiologist or a specialized nurse. Since most of these professionals were going to be needed by intensive care units, there were reasons to believe that the GI endoscopic activity would collapse during the pandemic. So a second aim of our work was to measure the impact of the COVID-19 on the gastrointestinal endoscopic activity in France. So we conducted a nationwide web-based survey on the endoscopic activity from March 23rd to 27th, 2020 among the 3,300 French gastroenterologists practicing endoscopy and collected data of 694 responders, which is about 20% of the total. First, virtually all gastroenterologists, 99%, had to cancel 91% of their endoscopy procedures. 74% of the endoscopy outpatient clinics were closed. Endoscopy could still be performed for the patients admitted to the hospital in 49% of cases for non-vital emergencies, for example foreign body removal, gastrointestinal bleeding without hemodynamic instability, caustic injection in 72% of cases, and for vital emergencies in 95%. Only 9% of the gastroenterologists eventually performed endoscopy in COVID-19 infected patients, with a median of 2 endoscopies during the week of the survey. A specific circuit for COVID-19 patients had been organized only in 44% of the endoscopy departments. Outside the endoscopy departments, about the third of the responders also took care of COVID-19 patients admitted to the hospital. Concerning the viral transmission among GI endoscopists, we had the surprise to find out that 57% of the responders performed GI endoscopy procedures without wearing a mask. This very high number can be explained by a lack of information, but also by difficulties obtaining personal protective equipment such as FFP2 masks, reported by more than half of the responders. Finally, 13% of the gastroenterologists reported symptoms compatible with COVID-19 infections. 5% were actually tested by PCR and 2% were confirmed positive, with one case requiring hospital admission. We believe that this data is valuable because it was collected at the peak of the epidemic in France. It points out the challenge of preventing viral transmission among GI endoscopists by providing timely information on viral transmission and personal protective equipments in sufficient number all over the territory. Finally, our data underline the huge number of endoscopies that will need to be rescheduled after the pandemic. To avoid too many delayed diagnoses, particularly in terms of GI malignancies, it will surely be necessary to temporarily increase the endoscopic activity, probably to improve the triage of the patients, and even possibly to consider the use of alternative endoscopic diagnostic techniques such as capsule endoscopy. Finally, I would like to thank my colleague and friend Belle, the administrative board of the SVED, and of course all GI endoscopists who took the survey and made the study possible.